And we'll go ahead and start off with David Dickinson, who's going to give us a talk and go over the article on foot care, since that's one of the biggest problems that marathon runners and sports runners can encounter. And then followed by that, Michaela will be telling us about ultra running. And finally, Julia, when she gets off her airplane, will tell us, go over the WMS guidelines on exercise-induced hyponatremia. So without further ado, David, you can take it away.
Thank you, Carver. Let me see if I can figure out how to share my screen here. Here we go. Share. That might actually work. Hmm.
And let's try and make this an interactive session. So pull up that chat window and throw your questions, comments into the chat while he presents. I will try to respond to any of those.
Apologize, I don't do this very often, so give me 1 second.
Take your time.
Yeah. Here we go. There we go. All right. Sorry about that, everyone. So this is a presentation I actually did at the Wilderness Medicine Conference on long distance hiking, um, foot issues, but I thought it was very apropos with the distances that trail runners will do typically, to talk about some of the foot issues that we will see in trail runners. The articles I sent out were more case reports, and I didn't think they went in too much depth of all the different things that we might see. So I thought I'd kind of summarize it in a PowerPoint presentation. So without further ado, here we go. No conflicts of interest or disclosure. So we're going to talk, I like history, so we're going to talk a little bit about trail running history. Then we're going to go into some special considerations that you should think about if you yourself are a trail or ultra runner, or if you're manning a station on a race course or during an event. And then we'll get right into the uh, different afflictions of the feet. So trail running history, I thought was interesting. The earliest recorded run in the mountains as a race was in 1040. One of the kings of Scotland had a race to determine who their postman would be. And actually, a lot of these early trail runs were to find out who would be messengers or mailmen. In the 19th century, we started seeing some hill runs called fell runs, like the Ben Nevis race and Three Peak race starting in England. Started getting a little more common on the main continent there in France, Italy, and Spain. And in America, John Muir wrote about running up Mount Shasta. And after people read his account, runners came from across the country to try to beat his record, even though he didn't really talk about how fast it took him. 1905, the Dipsea race in San Francisco was one of the first races that was uh, held in the United States as an organized trail run. And typically before the 80s, people just kind of stuck in their own countries. But in the 1980s, people started to travel across the ocean and to different countries. And uh, personally, I found interesting in the 2000s, we started seeing fastest known time races. These are individual races, but still these ultra runs, especially on some of the long trails in the United States. Things like the Appalachian Trail, fastest known time is 40 days, 18 hours, 6 minutes. That was set last year. PCT is 46 and a half days. CDT is 76 and days and 10 hours. So some uh, pretty remarkable times when you think about how long these trails are. So when we ourselves are trail runners or are uh, taking care of people who are on these long runs,
Looks
we
like it
really
is. Lauren, you going?
We need to think about some of the considerations. So environmental exposure, these people are out in all sorts of temperatures, hot and cold, different precipitation and moisture levels, which are definitely going to affect the feet. Rugged terrain, they're not always on roads, so a lot of times they're in the woods, so rocks, roots, leaves, plants, water, all things that can affect the feet. The distance of these races or training days, certainly those repetitive stresses on the feet can be very taxing. And then the drive to finish, whereas in the front country or on just a regular run, we may not ignore a pain or infection in our feet, but people are very driven to finish these long races because they've been training for so hard, for so long and very hard. So let's get right into it. Blisters. Most of us know about blisters. I'd be surprised if not one of us has never had one. So this is increased friction from the skin against an object. Usually it's the footwear. Sometimes it's a sock. And this is going to cause a split in that stratum spinosum layer of the skin. And initially there's just some inflammation, some redness, a little bit of swelling and pain. But further friction causes that layer to split, and hydrostatic pressure causes fluid to start flowing in, causing the blister. This is a very common problem in runners. One study had a blister rate of 26 to 76% in ultramarathoners, and about 40% reported that blisters actually adversely affected their race performance. Risk factors we're looking at that will cause blisters. Obviously, increased moisture is going to increase the friction. Increased temperature causes swelling of the feet and further splitting of that stratum spinosum. Obviously, the longer we're running, the more likely we are to get blisters. If we're using new footwear that's not broken in, causing pressure points in the feet, and obviously poor conditioning if we're not used to running. So when we do start getting those hot spots, reduction of friction is paramount. Putting some padding, there's some hydrocolloid or hydrogel patches or even moleskin, and good old-fashioned Leukotape can be put over it just to give another barrier to hopefully prevent things from progressing. Once they become more large, more painful, we do want to drain those. If we're in the backcountry, we want to try to do that as cleanly as possible. If we have a little alcohol prep pad or some soap, it's best to do that before puncturing it. And if there's any cellulitic changes, we want to be putting some people on antibiotics. Usually this needs to cover for staph or strep. So your first generation cephalosporin should be fine for that. Prevention, breaking in new shoes, whether that's going for shorter runs or just walking around in our day-to-day lives to help reduce those pressure points, getting on those hot spots really quickly. Reduction of friction, again, sometimes pre-taping is important for people who are more prone to blisters. And then reduction of moisture, things like changing socks or different drying powders like Gold Bond can be used. Water immersion foot injuries. So these are broken up into two categories, whether it's immersion in cold, non-freezing water. This is trench foot that we first saw in World War I described, or warm water immersion foot from water that's a little bit warmer. So cold water, they say 32 to 59 Fahrenheit. Warm water is 59 to 90. We first started seeing descriptions of warm water immersion foot in the Vietnam War. The mechanisms for these are pretty poorly understood. All right. They think that there's maybe some microcirculation damage, prolonged vasoconstriction, and reperfusion injury in cold water immersion or trench foot. In warm water immersion foot, they think it's a hyperhydration causing some splitting of the skin layers, leading to that inflammation. Typically, these feet need to be submerged for a prolonged period of time, for at least 48 to 72 hours, but you do start getting early changes prior to that. I'm sure most of us have either gone on runs on hikes and taken our socks off and started seeing the pruny feet like we see on the left there. Risk factors, obviously, water exposure. This cannot happen without moisture. Constricting footwear, not allowing things to breathe, especially like those waterproof boots, can really increase your risk of this, or waterproof shoes rather. And then inadequate calories or fluid intake can really increase our risk of developing symptoms. Trench foot, signs and symptoms goes through a few different stages. First, skin becomes red or pale or numb. Usually it's painless. Then turns into more mottled and blue appearance. You're going to have some bounding pulses, but the cap refill is going to start going down. Third stage kind of happens suddenly after a day or two. It will suddenly go from mottled blue to bright red and swollen and very painful. And there may or may not be blistering. And then it will slowly go back to normal. The cap refill will go back to normal, the skin will go back to normal, but people are often left with some cold intolerance and chronic pain or numbness. Warm water immersion foot, kind of like what you see on the left, white, wrinkled, painful, sometimes paresthesias. And tropical immersion foot, which I failed to mention in the previous slide, is kind of the more severe version of warm water immersion foot. If you don't dry them out, these become more burning pain, like a neuropathic pain, swollen. Sometimes there may even be fever or inguinal lymphadenopathy without any underlying bacterial infection found. And as these people recover, the skin usually desquamates and peels off. So for trench foot, for treatment, let's say you're out on the trail or on a run, you see this, we want to get their socks off, start drying the feet. We want to passively warm, unlike frostbite where we're dunking in water. We do not want to be dunking this in water because that was the cause. So just air rewarming, pain control. You can use NSAIDs and opiates. Interestingly, in the UK Armed Forces, they actually recommend amitriptyline for that nerve pain. Capsaicin has also been described as useful. There's really no clinical trials for pain control, so you just use whatever you feel would be most appropriate. Loose dressings just to allow those feet to dry out and allow circulation to get back to those areas. Warm water immersion foot usually just gets better if you keep it dry. There's no long-term sequela. And then tropical immersion foot, sometimes they need to be admitted for pain control. They need to be off these feet, elevating, and again, using that pain control for neuropathic pain. Plantar fasciitis. Most people have heard of this. So the plantar fascia is a band of tissue that connects our calcaneus to the flexor tendons of the proximal phalanges. And this provides support to the longitudinal arch of the foot. Plantar fasciitis is from prolonged and repeated microtrauma to this from walking or running. There's some risk factors for it. Arch abnormalities, flat feet or high feet. If you have limited dorsiflexion, like if you have Achilles tendinopathy or arthritic changes, that can put undue stress on your plantar fascia. Inappropriately fitted footwear, if the arch is too high or too flat, obesity, and ankle instability. These plantar fasciitis in the morning or when you first start running is typically going to be worse with those first few steps. And typically gets better as you exercise it, but once you rest and start walking again, the pain will come back, as opposed to the next thing we're going to talk about. Treatment, trying to be off of it as best you can, at least for a couple of days. Heel cushions or taping can help reduce the impact on that heel. Taping can help fix any of the arch abnormalities or eversion or inversion of the foot abnormally. Exercises or stretches, NSAIDs, and going to podiatry or foot and ankle ortho if no relief. Prevention, if you know someone who has foot arch abnormalities, you need to find the right inserts. Sometimes that does mean going to a podiatrist. And obviously well-fitting shoes, we want those to be snug but not too tight. Stress fractures. So this is an overuse injury, repetitive stress on the feet, like running. Classically, we're going to see these in the metatarsals. Sometimes it can happen in the talus and calcaneus. I've never seen it there, but it has been reported. And similar to plantar fasciitis, those arch abnormalities, tight Achilles tendons, obesity put us at risk for developing stress fractures. So if we have a stress fracture, obviously the pain's going to depend on what bone's affected. Metatarsals are a bit more anterior, calcaneal going to be under that tibia bone or on the calcaneus itself. Unlike plantar fasciitis, which typically the pain improves with activity, this pain is going to be with you from start to stop, and doesn't get better until you're off of it. And swelling is not always present because this is a more long-term repetitive injury rather than an acute injury that we can see from acute injuries. Treatment, we want to be off of this. We want to ice it, use over-the-counter pain medication, splint if you're unable to bear weight. And these really should be evaluated by a medical provider in the front country. X-rays are okay if you've had these symptoms for about 2 or 3 weeks. You can start seeing some evidence of healing, like in this X-ray on the left. MRI is the imaging modality of choice. And this takes a while to get better. Metatarsal fractures take 4 to 6 weeks, calcaneal or talar, sometimes 8 or 10 weeks. Paronychia, another thing that we see in some runners. This is bacterial infiltration of periungual tissues, usually staph or strep. I tried to see if there was any description of Pseudomonas, given that's in the shoes. I couldn't find any. So typically we're just dealing with normal skin bacteria. They're associated with ingrown toenails, which is a growth of the toenails into those lateral folds. Repetitive trauma can also push some of the bacteria underneath the nail, causing these infections. Signs and symptoms, usually it's red, it's swollen, it's painful. Sometimes we'll see some of that yellowish drainage like you see in the picture here. Left to its own devices, a purulent collection can form. That becomes very apparent with that nice white collection in the sea of red. Treatment, if you catch it really early on, you can sometimes just get away with normal topical antibiotics and warm water soaks. If you do see that white purulent collection, those need to be drained. And if there's extensive cellulitis, like I would say in this photo, I'd probably put somebody on some antibiotics. Your first generation cephalosporins, Bactrim, doxycycline. Pitted keratolysis, this is something that's actually pretty common in a lot of hikers and runners. This is a polymicrobial bacterial skin infection. Some of the bacterial species includes Corynebacterium, Dermatophilus, Streptomyces. And you're usually just going to see these crater-like pits on the balls and over the heel. Pretty malodorous. And usually this doesn't cause any issues unless you get the plaque variant, which there's a photo in the next slide. That can be actually quite uncomfortable. So it's good to keep this in mind if somebody's coming in with a painful foot. Hot, humid weather, poor foot hygiene puts us at risk of this. And again, typically it's not going to cause any issues unless you get this right here, this plaque variant. So typically it's going to respond to topical antibiotics like mupirocin or clindamycin. You do have to give it for quite a long time, up to 2 months. 2 months. And then frequent sock changes, keeping the feet dry is paramount. Tinea pedis, we've all heard of athlete's foot, fungal infection caused by a few different types of fungi that we pick up on surfaces, and they can colonize our shoes. Obviously, warm water and occlusive footwear puts us at risk for this. And there's a few different variants that we learn about interdigital, like in that previous slide. It's that cracked, white, macerated skin in between our toes that can sometimes be painful. The moccasin distribution, hyperkeratotic variant in the upper right-hand corner, causes those flaking skin. All right. For paronychia, do you always cover for MRSA, purulence, abscess? I typically do. Thank you. Yeah, I typically do cover for MRSA if I see a purulent drainage or purulent collection. Then there's a vesicular bullous kind of in the right-hand corner there. These can be very uncomfortable, just vesicles with erythema surrounding it. And these these can turn into bacterial infections, secondary bacterial infections. So, if you get somebody who has athlete's foot findings, but also has fever, they're tacky, altered, think about a septic picture in these people. It's not common in my experience, but it can happen. Treatments, your topical antifungals like azoles, terbinafine, pretty useful here. I don't usually have to resort to oral antifungals like diflucan for this. I think that's overkill. Um, and then proper foot hygiene, again, keeping things dry, uh, changing socks, things of that nature. And lastly, subungual hematomas. These are fun to take care of, but not fun to have. So this is when blood collects between the nail bed and the nail. Sometimes it's from direct trauma, like a sudden hit to the toe or, rock drops on it or something, but it can also be caused by repeated trauma to the nail, causing microbleeds in the capillaries of the nail bed. Typically, you're going to see what you see on the left here, purplish bluish discoloration under the nail. And these things are quite painful. You have to think that the nail is actually being separated from the nail bed from this blood collection. How you treat these, if it's less than a couple days old, you may be able to trephinate it. This is why I always have a needle in my kit when I'm hiking or if I'm working a detail. You just kind of twist it slowly over the nail until you get blood coming out. Don't worry about hitting the nail bed. The blood collection is actually pushing the nail bed away for you. Obviously, you need to clean the nail before you do that. If it's more than 48 hours old, I would still try to drain these. There may still be like a serosanguinous collection underneath, but don't be surprised if you don't get anything out. Sometimes if these hematomas are large, they can actually go into the eponychial spaces and go up the finger. Those are usually for more direct trauma, and there can be a concern for fracture underneath those. So after draining it, they usually need to get x-rayed. And prevention, proper nail care. I want people to cut their nails back pretty far, but straight across to hopefully prevent any ingrown toenails, and getting properly fitted shoes so you're not hitting the front of the shoes as you're running. And just kind of going over prevention, we need to get our shoes properly fitted and break them in properly. Air your feet out as best you can, washing your feet and changing your socks to help cut down on infection risks like epididymitis or athlete's foot. Hot spots you need to get on right away, or else they are going to get worse. Clip your toenails correctly, as I just said, and addressing pain that is constant or not going away, just so you're not worsening anything like plantar fasciitis or stress fractures. And that is my presentation. Does anyone have any questions?
Looks like there's one question in the chat about tincture of benzoin. Is it beneficial for blister care in cleaning the area or helping the moleskin or KT tape stick?
Um, I would definitely try to clean you can definitely use the tincture of benzoin to clean the area to help it stick better. Obviously, it's going to stick, tape's going to stick better to a dry skin. So I would definitely clean, especially if it looks dirty or there's debris around it. I personally like Leuko tape because it seems to stick through a lot of different uh, levels of moisture and swelling of the feet.
Any other questions? Feel free to just unmute and ask away. If not, then we'll probably have Julia present next since she is traveling, and we will try and get her to do her presentation so she can continue her travels. Michaela, if you go last, if that's all right. All right, if no other questions, take it away, Julia, telling us about the WMS guidelines.
Okay. If it gets too loud, just interrupt me and tell me to stop, that's okay. And I can
Sounds good
always
now.
move to a quieter spot. Okay. I'm in the airport, so bear with me, everyone. Let me just share my screen. Can everybody see my slides okay?
Yep.
Awesome. So I'm Julia. I am a first year emergency medicine intern at Virginia Tech Carilion. And I've been hanging out with some of the wilderness medicine folks down there throughout medical school. I went to become for medical school and I've done a lot of ultra marathon coverage with them. And so this has been a space that I've been really excited to get to speak on and get to do more research for my own knowledge because it's something that I want to do in the future after residency for sure. Um, so I was covering the Wilderness Medical Society clinical practice guidelines for exercise-associated hyponatremia, and this is the 2019 update. Um, and really, these clinical practice guidelines were looking at how previous reports and articles focus on EH and organized endurance events. And they look at how we typically see reports in front country environments, but there's a wide range of endurance events that take place in the backcountry, and we don't necessarily have as clear guidelines for those. And that's why they had developed the initial guidelines and then now are repeating those um, for the 2019 update. There we go. And so the way, just kind of reviewing at the beginning, and I have no disclosures, I don't make any money off of any of this, but reviewing kind of the methods that they use to come up with these guidelines, they developed an expert panel, and this expert panel was comprised of a number of different individuals, a lot of emergency medicine folks, but they also had nephrologists and other individuals on there from pre-hospital settings to hospital-based settings. And this all happened back in May 2018. Um, they used a search looking through Medline, the U.S. National Library of Medicine, and National Institutes of Health for their articles. And they were looking at articles published between 2014, which is when the last update or last clinical practice guidelines for EAH were published through 2018. And then they weighted all of these articles. They really only didn't accept abstract only um, articles. And so they weighted the level of evidence supporting each of those conclusions based on the various types of studies and the strength of those studies. And then they used the American College of Chest Physicians grading system. And I'll go through that in a little bit once I kind of pull up all of the specific guidelines. And really their goal with this clinical practice guidelines were to develop evidence-based practice guidelines for the acute care of EH for use in our resource limited settings, so wilderness, military training and operations, and then multi-hour, multi-day endurance competition, and during transport with EMS. So, just kind of a basic review of what EH is. It's going to be a serum or plasma sodium concentration below the normal reference range of 135 that occurs during or up to 24 hours after any sort of kind of prolonged physical activity. And you can have, these folks can be asymptomatic or symptomatic. Typically, we see the asymptomatic EH in screening protocols or when blood was drawn for other reasons, and that's how we know that they had EAH. And the article talks about how the highest rates of asymptomatic EAH are 30 to 51% in a 100-mile ultramarathon in North America. Looking at one of those studies, they had seen that. And so it's obviously very prevalent. We just don't always we're not always seeing these folks um, in our care. They don't always come for care explicitly. But we can see these in endurance athletes. We can see it in hikers and anybody who's really going out into the wilderness, especially in temperature extremes in the military. So there's a lot of intersection here with wilderness medicine, tactical medicine, sports medicine, where we all kind of care about the same thing. And just kind of doing a quick review of our signs and symptoms for exercise-associated hyponatremia. There's mild, they group it into mild and severe in this article. Mild is going to be, it presents a lot like a lot of other things that we see, especially for the most part, I do a lot of running ultra marathons. I've done some other events, including biking and things like that. But in the runners, especially, like seeing them feel fatigued and weak and irritable and having a headache or being nauseous and having runner's gut is very, very common. And so teasing out when this may be a mild EH scenario versus just kind of normal, you're running 100 miles and you're doing a lot to your body, is hard, can be difficult to do. And a lot of these signs and symptoms also overlap with heat exhaustion and dehydration, which makes it even more complicated for the practitioner who's working on diagnosing them or for pre-hospital folks. Um, and you can see once we move into that severe category, you start to see more obvious signs. You get altered mental status and respiratory symptoms are the big two, seizures, coma, things that we hear about in school when we think about hyponatremia in the inpatient setting, especially. Um, and the incidence of, since they comment that the incidence of symptomatic EAH in all marathon participants is typically less than 1%. But when you look at Ironman triathlons or ultra marathons, you start to see those numbers rise to 23%, 38%. And they're also seeing it in shorter distances, so half marathons and sprint triathlons. And sprint triathlons are only about 90 minutes distance, or can be as short as that. So it's more, like I said, more common than we think. And so it's something that we need to kind of be aware of these symptoms and be aware of how they cross over. You can see A is all the ones that are crossing over with heat exhaustion and dehydration in their table. Okay. And so why do these athletes get EAH? So the big reason, the primary mechanism is that they're over-consuming hypotonic fluids. So really they're drinking too much, and they're drinking more than they are excreting. There's also this combination of non-osmotic stimulation of arginine vasopressin or antidiuretic hormone, and causing that to secrete more and then subsequently retain more fluid, and reabsorb more fluid when you look at your distal tubules. There's also a hypovolemic form of EAH, but a lot less commonly. The one that you typically will see is people are going to be hypervolemic. They're going to be drinking too much and they're overhydrating in excess of what they're losing from their sweat and their urine, and then respiratory or GI losses. And they've typically seen in reports weight gain in athletes who are doing these endurance events. They haven't seen this and hasn't been studied in hikers, for example, but it's very likely that you would, start to see some of the similar signs and symptoms. And we're not expecting any of these athletes to gain weight as they're, going and doing these endurance events. If anything, we would expect the opposite. And so that's when red flags really would start to be raised. But we're also not routinely weighing our athletes throughout the race, right? And there was a really interesting point that they had brought up, and they had talked about how, in theory, we should be able to consume like 1 to 1.5 liters per hour before we start to develop this water retention and this hyponatremia, if you just kind of going by the book. But obviously there are other factors, and that's where they're kind of tying in this ADH, limiting renal water excretion and preventing water retention, because that can be released from pain, emotional stress, physical exercise, nausea, vomiting, hypoglycemia, exposure to heat, and medication use, all of which happen in all of these outdoor events. And particularly they commented on NSAID use. And that was something that I found to be particularly interesting, just from anecdotally and from my experiences, having seen a lot of the ultra marathoners turning towards NSAIDs for pain control to get them through some of these endurance events. And at the medical tent, we're not providing those for them. We really stray away from it, especially with the prevalence of, and the worry that could develop rhabdo, and they have all this muscle breakdown and are developing, acute kidney injuries. And so all of that kind of just compounds on each other, and really makes it easier for them to overhydrate. And so risk factors for EAH, like I said, obviously the big one is that they're consuming too much hypotonic fluid and taking too much. Heat is going to be another one. The longer they're exercising, kind of as you would suspect. Nausea with or without vomiting can be a risk factor, and NSAIDs, like I was just talking about. And then in the hypovolemic case, having chronic diuretic use or having higher sweat sodium concentration, this could be with or without cystic fibrosis. Those can all kind of contribute. They didn't see there was no statistically significant difference between male and females in terms of risk factors for developing an EAH. And this is ultimately, I'm going to go through after this all of the specific guidelines and recommendations that they made in this paper. But this was really their overall kind of treatment pathway. And so I wanted to make sure that everybody had the chance to see this. Generally speaking, if you have, and this is looking more when you have, when you're starting, you have a runner come into your tent, or if it's a different type of endurance event, or you're, intervening in a different setting, you have your patient come in, and it's really, if you're suspicious at all for EAH, or it's a kind of distance endurance event, you're looking really, the big thing is, do they have any sort of alternative status? Because that's going to help you determine if they're severe versus mild, if they do have, if they are hyponatremic. And they list the symptoms that we've already kind of gone over here. And obviously, considering alternative diagnoses, like I said, there's a lot of correlation between symptoms. And certainly when you have a patient come in who's syncopized or collapsed, it's hard to tell if they collapse because they're hyponatremic, or if they're maybe hypovolemic and dehydrated, or if there's a cardiac issue going on. And so there's a lot of differential diagnoses that are happening all at once. And we'll kind of go through how to tease those out and how to treat those as well. But as you consider your alternative diagnoses, if you are thinking that this is going to be exercise-induced hyponatremia and you're on the severe pathway and they have altered mental status, your treatment is going to move into your hypertonic saline, and we'll go through the specifics of that as well. If they do have altered mental status and you don't think it's EAH, then you're treating more on a heat stroke pathway or a dehydration pathway, which is going to be your cooling. If it's dehydration, you're also giving fluids. If you don't have altered mental status, you're moving to the right side of this flow chart. Again, considering your alternative diagnoses, but for your EAH, you want to fluid restrict. You can give them salty snacks or high sodium drinks, oral hypertonic solutions, and you really want to monitor them if you can. Whereas if it's more of a heat exhaustion picture, dehydration picture, that's when you're doing fluids, you're still trying to do your hyperthermia treatments, and you're working to cool them down. And so you can see how those are very different in terms of fluid restriction versus providing fluids. And that's where we need to have a higher index of suspicion. And the way we really do that is going to be by going through and taking a good history. So these are the recommendations, and I compiled all of them into different slides so that I know there's a lot of text on this slide, but it's really just so I can show you all of the groupings of recommendations. And the way that the grading system works is that they either grade it as a strong, which is a grade 1, or a weak, which is grade 2, according to the balance among benefits, risk, burdens, costs, and degree of confidence in estimates of these. They also grade the quality of evidence. So an A is going to be a high grade of evidence, B is moderate, or low is C. And so that's how when they look at the study design, the consistency of results and the directness of evidence. And so the first two don't really need too much explaining. Overall, the primary risk factor is that these folks are overhydrating and overhydrating, and that's going to predispose them to develop EH, and they need to avoid that. And that's really what the second one says as well, is that any participants need to avoid overdrinking, right? The next step was they kind of touched a little bit on once we get these folks into a hospital, because ultimately, as we do our treatments in the backcountry or if you're in a front country event, we ultimately need to get them to EMS to the hospital if we think that they're severe enough so that they can have further evaluation. And so if you're in the hospital, which you're probably already doing, if you think that they're hyponatremic, you're getting a sodium. And so a lot of these 1A recommendations aren't, ground shaking, but they're just kind of reiterating things that we already typically would think about in this scenario. Problem for us is a lot of times in the backcountry, we can't use those ISAT monitors. They have a narrow window range that they work in. It's great if you're in the main medical tent for a race and you have an ISAT to look and try to get sodium, but a lot of times that's not the case. And so it's a lot more history and physical. And so that's where when you're seeing these folks, the next one talks about looking for cerebral edema or non-cardiogenic pulmonary edema. So those altered mental status and your respiratory distress signs. If you suspect they have EAH, you're trying to determine that severity. You're really going to start and go through how their history and go through how have they been drinking. And that will help you determine if you think that they are overhydrating. Like I said, we were going to touch on the hypertonic saline. And so if you have a patient who's severe, and this is going to be when you have those altered mental status changes or those respiratory changes, if you've confirmed that with an ISAT or you're in the hospital, it's a different scenario. But if you're in the backcountry, you've confirmed with an ISAT, or they're symptomatic and have those altered mental status changes or respiratory distress, and they have those severe symptoms, they are recommending treating with 100 milliliters of IV hypertonic saline, and you can repeat that twice for a total of 300 milliliters. You'll do this in 10-minute intervals. And ultimately, that will aim to increase serum sodium by about 4 to 5 millimoles, and that will reverse any potential cerebral edema that is developing because of the hyponatremia. With that, it's like I said, differentiate if they've experienced a collapse in hot weather. And so if you think this might be heat illness, the way that they're recommending is that we start cooling and we start preparing as if we need to give this hypertonic saline until we start to clarify. If they start improving with the cooling, we may not need to jump to giving hypertonic saline. But ultimately, this is an acute process, right? This is not your little old lady who comes in and is chronically hyponatremic, and we worry about osmotic demyelination by overcorrecting sodium. This is an acute process, so us giving 100 milliliters of hypertonic saline is very safe. There's been no reported cases of osmotic demyelination with this treatment to date. They also talk about patients having received significantly more hypertonic saline than they are recommending without complications. And ultimately, the theoretical risk is if you give somebody who is hypernatremic and they have elevated sodium, you give them this treatment, you're going to elevate their serum sodium 1 to 2 millimoles. The caveat to all of this that they did mention, and this is why it's important to consider your heat-related illness and dehydration, is that your collapse runners are more frequently going to be hypernatremic than hyponatremic. And so they're more likely to have been vomiting and have collapse because of dehydration or heat illness. It can have very similar symptoms. So it can have nausea, vomiting, diarrhea, headaches, muscle cramps. And so just starting with that pathway and really making sure that you keep your differentials in mind as you're going through these. They've also gone through and they've showed that runners have really poor understanding about the relationship between drinking habits and hyponatremia. And they feel that you can likely extend this and extrapolate this into any wilderness recreational folks. There's also a large knowledge gap that exists internationally that they comment on among practitioners and pre-hospital folks about the assessment and treatment of exercise-associated hyponatremia because it's such a nuanced diagnosis, especially when we don't have that data to back it up, that concrete biochemical data. And so a lot of times this can be mistreated because we're thinking it's dehydration, and we talked about how that's a reversal of treatment. And so a lot of times you'll see that the field response is to be like, okay, let's drink more fluids, or we're going to give you IV fluids, give them all saline. And you think that they're dehydrated, and that's ultimately, if they are hyponatremic, that's going to increase the morbidity and mortality. And so making sure that participants are aware that they should not be overhydrating, and medical staff are of aware to be suspicious for this and how to rule in or rule this in or out, and be aware and monitoring for it is really important, because ultimately the really big thing here is going to be prevention. If we're in the backcountry, there's only so much we can do, and it makes it a lot easier if we don't get to the point where we need to be thinking about our hypertonic saline or anything like that. So if we can prevent this, this will be a lot easier for us as medical practitioners, but then also for our patients. Ultimately, the big thing and the big recommendation that I've always given and I've always been told to give, as I've started getting more and more into race coverage, has been that participants should be drinking to thirst. There's a lot of them who come in and they've like almost over scienced their preparations, and they have a very specific fueling strategy and hydration strategy in mind. And something which may work when they're training, but something changes on race day, and then all of a sudden they're overhydrating. And it's very, very easy for them to do this. So whenever I hear that somebody is drinking scheduled, and they're scheduling when they're drinking to make sure that they hit a certain amount between each aid station or something like that, that's when you start to get concerned that maybe they're starting to develop hyponatremia, especially when you have those signs and symptoms, and they're kind of putting themselves at risk for that. And so really the big recommendation and the big way to educate them is to just have them drink to thirst. There's also, like I said, a very specific scientific way to do that, and they can estimate what their fluid needs are going to be and assess body weight losses per hour, and it's a lot of math. A lot of these folks don't necessarily do the math. It's more that they've kind of looked things up and they figure out that this is what I think I need to do. Specifically, and not that a lot of times we're doing this at some of these events, but just because they've lost weight, or they haven't lost weight, but they haven't weight loss or lack of weight loss, you can't use that to exclude exercise associated hyponatremia. The only thing we can really do with weight is that if they've gained weight, again, this means that you're taking weights at some point from the beginning to the middle, which doesn't typically happen. If they've gained weight, reduce their fluid intake. And a really good way to help with this as you're kind of setting up your aid stations and medical tents and things is making sure that you restrict fluid availability, and give them options for fluids that are going to be more hypertonic in nature inherently, and that they have options for saltier snacks and things like that. So they're not just guzzling water, but they have a variety of options. And that's typically what I've seen at a lot of these ultramarathons, and that helps. And you can kind of tell who's going for a variety versus who's going just for the water cooler. A lot of them use Tailwind is the specific one that I see at the ultramarathons I do. And that's, depending on how they mix that, can become hypertonic or can just be isotonic. But at least it has a little bit more solutes in it compared to just free water. And then oral fluid restrictions indicated if EAH or fluid overload is associated with mild symptoms, and that's kind of what we're talking about. So really, if you think that you think they're hyponatremic and it's mild, you want them to be restricting their fluid a little bit. They're not going to completely do it, especially if they're in the middle of a race, but trying to get them to do some of those fluids that have more solutes in them, having them drink broth A really easy way is we can use, and this kind of goes into the next one, but we can use oral salty fluids to help rehydrate. I'll touch on that in a minute. They recommend that we observe patients for at least 60 minutes after exercise to ensure that they don't decompensate after they finish exercising. And certainly, I think it's a recommendation that I would bring into practice. I think it's easier said than done, because some of these folks, like we were talking about in the last presentation, are very determined and they just want to finish, and they're not, they're not super, not that they don't care, but they want to get, they've been training for this for a while and they really want to get to the finish line. And so they're, especially if you see them in the middle, it's a lot of it is playing a kind of a game of trying to discuss with them that, the risks and benefits, and hoping that, I really don't want to have to rescue you down this trail, because if you collapse in the middle of the trail, it's going to go a lot worse. And a lot of this is kind of, a lot of these recommendations really repeat themselves. And so I know I've been repeating myself a lot. We've kind of talked through that, you don't want to give hypertonic fluids when you think that they're fluid overloaded. You want to restrict. And the way that they are saying that you can kind of help monitor until your restriction, when you can kind of start to back that off, is when urination begins, you can kind of back off. And remembering that you may have some AKI going on, especially in these endurance athletes, just from muscle breakdown and just inherently what they're doing as their exercise. And we've kind of touched on the other two. They really, some of these recommendations repeat themselves in just slightly different ways. We already talked about the IV boluses, and that we want to avoid isotonic or hypertonic rehydration. And these ones are arguably the least, these are the weaker recommendations, but I think these are the ones that we see more commonly, this first one especially more commonly in our events, is that there, and I have a picture on the next slide, but there's a whole lineup of snacks at these, if you've not been at an ultramarathon kind of event, that these runners get. And so there's pretzels and candy and cookies, and they have pierogies and quesadillas and pickle juice, and they have a whole variety. And a lot of these snacks are tailored, and chips and things that are tailored to try to help them get some salty snacks. When we have folks who we think are mildly hyponatremic, a really easy way is having some sort of broth that they can drink, and that's very commonly available. We either have ramen packets, and you can put a few of the ramen packets together in a small amount of water, like half a cup, with a couple of ramen packets, which makes a really salty drink, and it's not super fun to drink, but that helps get oral sodium. Versus you can also do Beyond Cubes if you have, or just having like pretzel sticks and things like that are going to be higher in sodium content, can really help kind of prevent this, or treat it in its early stages. The big thing is, if you start to catch these folks and you think that they are overhydrating, you have to stop the overhydration, because giving them all the salty snacks is not going to help fix the problem, because the overhydration is going to win in the end. And so it's really catching them, getting them to stop the overhydration, and hopefully getting them enough kind of salty food to keep them in a good balance so that they can finish their race. And then they did mention, just like we were talking about, that kind of disconnect between and the difficulty with diagnosing. They mentioned just kind of specifically alerting whoever, if you are that kind of backcountry provider and you're passing this patient along to EMS, or your EMS and you're passing this patient along to an in-hospital provider. They mentioned just when transferring that care, making sure that whoever is receiving the patient is aware that you think that this might be exercise-associated hyponatremia, and that you are intentionally withholding hypotonic fluids. And this is what you're thinking, so that you don't have things will get lost, and then they start to get hypotonic fluids because they're assuming that they're dehydrated, or um, dealing with heat illness. And certainly, obviously, we can be wrong and have to change treatments. But as long as we're, making sure that everybody's aware and kind of having good handoffs of care. Um, and so overall, really, the big things, right? We have this number, we have this less than 135 millimoles. We're probably not going to see that if we're in the wilderness setting, because we're probably not checking it, because chances are the temperature isn't right for the ISAT or we don't have it on hand. And so knowing your signs and symptoms is going to be key here, and taking a good history and really finding out how they've been hydrating. And if they are hydrating on a schedule, you're more likely than not they're going to be on the pathway to develop it some form of hyponatremia. And so really educating them, ideally educating them before the event, but if not, catching them while they're running and making sure that they know just to drink to thirst, and that they're continuing to eat and get electrolytes in through their food or through additional supplementation, tailwind, things like that. And then ultimately just trying to work to make sure that everybody is aware, as we do these handoffs, of what EAH is and then how we should be treating that in comparison to our heat-related illness and our dehydration. And so there's a picture, like I said, of kind of just some of the snacks, but there's always a ton. Any questions for me? I know that was a lot and a lot of repetitive things, but I think some of it was helpful the first time I was hearing a little bit. I don't know if I missed anything in the chat.
Thank you. No, that was a great review. Thank you for that. And if there's no other questions, Michaela is going to tell us about ultra running.
Sorry. Okay. How do I do? There we go. Okay. Hi, everyone. My name is Michaela Peters. Can you all hear me okay?
Yep.
Okay, great. Thank you. I am a third year medical student in Colorado. I've had a particular interest in ultra marathons. I've ran a few, volunteered at some aid stations. I'm currently training for a few races this fall. And as a result of my background, I'm excited to dive into this article, which looks at the limits of ultra endurance running from a physiological, psychological, and evolutionary perspective, highlighting how considering these multifaceted components can inform the care of athletes in wilderness medicine settings. So this article asked these main questions: what limits ultra endurance running performance? How do physiology, psychology, and evolutionary factors interact? And what strategies might help to mitigate those limits? So the next few slides contain tables that were included in the article highlighting various factors that can influence race performance leading up to, during, and following ultra endurance events, all of which we'll delve more in the coming slides. So this first table summarizes various components that influence race preparation, such as training history and load, terrain-specific preparation, such as hills, altitude, heat acclimation, individualized nutrition and hydration strategies. These tables summarize factors that come into play during the race, including things such as environmental considerations like heat, cold, altitude, underfoot terrain, pacing and self-awareness with things like monitoring hydration, fatigue, sleep deprivation, GI tolerance and accessibility of fuel, and different equipment choices such as poles, different types of running shoes, clothing choices, that kind of thing. And the last table highlighted factors that are more dynamic across the race timeline, such as increased heart rate, oxygen cost, fat reliance, neuromuscular fatigue, tissue damage, and core temperature, as opposed to decrease things like hydration, cognitive function, decision making, reaction time, and how those components can impact race performance, and then perceived effort and motivational fluctuations. And so overall, the themes were multifactorial with no single limiter explaining ultra endurance running, and dynamic with components that matter early on in a race potentially not being the same later on, and it's interdisciplinary with intersections amongst physiology, psychology, environment, and strategy all interacting with one another throughout that course. So, what is ultra endurance running? It's defined as anything longer than a marathon of 26.2 miles, with the most common distances being 50 to 160 kilometers and varying greatly in the number of hours. So, ultra endurance today, the article put in that participation has greatly increased in recent decades from fewer than 20 events before 1969 to over 7,000 events worldwide in 2019. And with the increased growth, there have been higher dropout rates at races like UTMB and Western States, having over one-third of participants having a DNF or missing cutoff times. So they wanted to take this information and ask the question, what's limiting performance and how can we prepare better for those challenges? And then I just included some different articles in here from another presentation that I gave that are just highlighting some of the injuries and fatalities that have occurred during ultra endurance events, many which are linked to extreme or rapidly changing weather and result in medical complications. Again, kind of asking how athletes can better prepare and how medical providers can prevent those complications from occurring in the first place. They looked at evolutionary framing and they kind of emphasized that from an evolutionary standpoint, humans have unique adaptations for endurance, including sweating efficiently, which allowed our ancestors to hunt by chasing prey into hyperthermia, having a pretty high fat buffer that can give, or a high fat content that can give an energy buffer, and being able to adapt phenotypically with more red blood cells, capillaries, and mitochondria when training demands those things. But it's argued that modern ultra running far exceeds ancestral activity, with ancestors not really running 100-mile races. So modern ultra endurance running and the adaptations can expose vulnerabilities as well, especially considering dehydration, fatigue, and GI limitations. And then they also emphasized that ultra endurance running is largely a weird phenomenon in which Western educated, industrialized, rich economies are mainly the ones participating in ultra endurance running, so it's not necessarily representing our species as a whole. So, diving into some more of the mechanics, the oxygen delivery and running economy. So, critical velocity is defined as the fastest pace a runner can sustain for a prolonged period without fatiguing rapidly. Physiologically, it's representing the threshold between exercise that can be maintained aerobically and exercise that is going to quickly just cause fatigue because the oxygen demand is outpacing the supply that is available. In trained runners, critical velocity is typically around 90% of VO2 max, but ultra runners generally perform at much lower intensities, more like 50 to 70% of VO2 max, depending on the race length. And below critical velocity, oxygen use is stabilizing and fatigue develops more slowly. But above critical velocity, oxygen consumption continues rising until VO2 max is reached, which is causing fatigue to set in quicker. And so they found that performance depends not just on the VO2 max, but on where the critical velocity is starting and how it's declining throughout the race. And then running economy is defined as how much oxygen is needed to maintain a given pace. So in marathons, the running economy is predicting performance pretty well, but in ultra endurance running, it's less predictive because terrain, duration, fatigue is all causing a shift in metabolism over time. So instead, flexibility and aerobic metabolism and oxygen uptake kinetics may matter more, is what they're finding with all of that. And this figure on the right is kind of summarizing all of that, illustrating the relationship between work rate, time, and oxygen use. with VO2 max setting the upper ceiling of aerobic performance, critical velocity gradually declining over time, and that middle band representing gas exchange threshold and lactate threshold as another marker of when exercise is shifting from being sustainable to causing more fatigue. So demonstrating how performance is depending less on hitting that VO2 max and more on how well runners can maintain work rates below critical velocity over many hours, despite things like fatigue, terrain, and environmental stressors. In considering metabolism, the article summarizes metabolism in ultra-endurance running by fuel use shifting over time towards fat, which is yielding less energy per liter of oxygen compared to carbohydrates. This is less efficient, but it's often unavoidable because GI tolerance ends up limiting how much carbohydrates can be consumed during the exercise time. For biomechanics and cost of running, the cost of running is referring to oxygen or energy cost per distance. Strategies to mitigate the cost improve performance, but in ultra-endurance running, preventing muscle and tissue damage may be even more important than strict efficiency. So things like trucking poles can increase energy cost but decrease load off the legs. And over distances, that trade-off might help preserve function. As fatigue accumulates, gait changes occur, things like increasing step frequency, reducing flight time, stiffening posture. And the article argues that with those things, those adaptations may be protective by attempting to limit the impact of stress on the body and helping to preserve muscle function in extreme distances. For thermal regulation and hydration, tying more of the evolutionary aspect into it, the article highlights that humans evolved in the tropics and excel at dissipating heat, but ultra-endurance running, the heat management becomes a key limiter with balancing sweating and stabilization of all of the thermal regulation factors over long distances. A main thing was conservative pacing is strongly recommended overall. And like Julia just wonderfully explained, the hydration strategy has shifted from a fixed fluid replacement, which a lot of athletes are still wanting to do. I've seen that at aid stations as well, where they're coming through and have a regimen of how much they think they should be drinking and how many electrolytes they should be drinking per hour, but that recommendation is just to drink to thirst, so there's a reduction in the hyponatremia that's occurring. And findings have shown that elite runners can often tolerate 3.5 to 4% of body mass loss without major issues, but like we just heard as well, it's really hard to be measuring that, especially out in the field in the backcountry. Heat acclimation over at least 5 days is strongly recommended as it can expand plasma volume, improve sweating efficiency, and even improve VO2 max and lactate thresholds. And then for cold environments, the main recommendations are protection of extremities and balancing insulation with sweat management. Considering GI distress, it seems to be pretty universal for most runners experiencing at some point. In one study, 96% of Western states runners reported GI symptoms, with nausea and vomiting being reported as leading causes of DNF. Risk factors for GI distress include heat, duration of running time, and pre-race anxiety. And so delving into nausea a bit more, mechanisms of nausea during ultra endurance include reduced gut blood flow and oxygen delivery, sometimes as much as 80%. That is occurring due to splanchnic vasoconstriction, that's shunting that blood to exercising skeletal muscle, the heart, lungs, and also as a result of that shift of the blood and oxygen, that's causing an increase in gut permeability and endotoxin release. And heat and stress hormones like catecholamines also worsen nausea. Strategies to mitigate nausea include heat acclimation, avoiding both over and under hydration, and limiting foods that slow gastric emptying like fat, fiber, or protein. Carbs should be a glucose fructose mix of about 50 to 60 grams per hour, trained ahead of time. So, kind of training to eating that amount every hour. And elite athletes may push up to 120 grams per hour, but that's not often tolerated by everyone. Um, and so, some different nutrition strategies. The energy expenditure can be pretty huge. While higher carb intakes may benefit shorter, faster events, longer races usually require more moderate intakes due to the tolerance of consuming that amount per hour. High fat diets increase fat oxidation, but evidence that this improves ultra endurance running outcomes seems to be lacking, especially with the timing of things. Flavor fatigue is pretty common, so rotating tastes and forms might help. Hydrogels may increase carb oxidation, but the evidence on that seems to be pretty mixed and also needs to be looked into more. And then other things to consider include iron and vitamin D deficiencies that are pretty high, particularly in women, and relative energy deficiency in sport, which is also seen amongst a lot of athletes and can impact health and performance. My favorite on longer runs is always potatoes, and I'd have my mom come to events and just hand out baked potatoes on the side of the trail. So that's always worked well for me, as opposed to just gels for hours. And then psychology. Psychological traits and strategies are also really critical in addition to all of these physiologic things. It's been shown that ultra runners are typically very intrinsically motivated, with task-oriented rather than ego-driven goals. The biggest motivator seems to be achieving personal goals, followed by health and self-esteem. Commonly employed coping strategies that were highlighted include goal setting, positive self-talk, attentional focus, visualization, and seeking social support. And managing boredom is also extremely important and came up as one of the things that a lot of athletes struggle with, especially on these longer runs, is just continuing to push through with that boredom present. And then ultra runners tend to be more resilient and mentally tough than other athletes with higher pain tolerance and lower pain-related anxiety. And they kind of highlighted in the article also that whether that's a pre-existing trait or developed through training is also unclear and another area where research could be done. In considering fatigue, the article considers fatigue in two ways. The first, perceived fatigability as the rising sense of effort that influences pace or dropout decisions, and performance fatigability by measurable declines in strength, neuromuscular function, or cardiac output, both playing a role in performance as a whole. So, some limitations of the research. Despite a growing interest, research in ultra endurance running is still pretty limited with a lot of gaps. Most studies are observational or lab-based, often on treadmills or flat terrain, which isn't reflecting real-world mountain races and the different difficulties that can come with terrain, weather, all of those different kinds of things. And controlled trials are difficult due to high variability in logistics, so statistical power is often pretty low in the studies that can be performed then. And key areas for future research include fatigue mechanisms, nutrition strategies, training interventions, and environmental adaptations, along with a lot of other gaps as well. To summarize, some conclusions. Ultra endurance running pushes physiology and psychology beyond ancestral limits. Major limiters include thermal regulation, GI distress, fatigue, and psychological resilience. Success depends on conservative pacing, heat acclimation, personalized hydration, and nutrition, with mental coping strategies also being pretty critical. And preparation must be interdisciplinary, not just training mileage, but also physiology, nutrition, psychology, and environment. And then there were some questions, and that is all I have.
Questions from anyone listening for Michaela or any of our other presenters?
Hi, I have a question that's probably for the last two lectures.
Sure.
Um, I work in Colorado and I was recently working at Ultra and I had a call from a patient at 55 miles who was starting to cramp mildly, but not super severe cramping, but was having a cola colored urine. Was probably like 5 miles from the next aid station. And I guess like in that situation was tolerating PO, not confused, overall doing well. And so was told to like continue to hydrate as he gets to the next aid station for further eval. I think my two questions as I was trying to deep dive a little bit was when it's cola colored urine, is that an immediate you're out of the race because of too much high risk for rhabdo and electrolyte imbalance? Or if they're tolerating PO, is it okay to recommend fluids and continue to keep going on the race? And then my second question was about what type of fluids would you use? Because obviously, I think I was more concerned about hyperkalemia. And so I didn't want to tell him to just do hypertonic saline type oral hydration, but I don't know if there's a recommendation. I tried to look it up. I saw like oral alkaline solution or hydration is an option because it's low in potassium, high in sodium, but just wanted to see if there's any thoughts on the case.
Yeah, so I mean, there's definitely quite a few things that could cause the cramps. I would keep heat illnesses high on your differential too. So heat cramps, it could be something related to sodium or other things going on. And then cola colored urine, from patients that could be anything from a slight discoloration from their normal to completely red or brown urine. And the most severe form that could definitely indicate something bad, like severe dehydration from rhabdomyolysis. It could also just be darker than their normal urine color because they're a little bit dehydrated, a little bit hemoconcentrated. And so really, I guess getting a little bit more history and kind of delving into that. And are they having any other heat-related issues versus any other concerns for um, sodium or electrolyte imbalances? So getting a history on their water intake. Are they taking salt tabs, just plain water? Um, that would be probably my recommendations. Any other
Right.
thoughts?
Sorry, just to follow up, it was middle of the night, not over. He was using salt tabs and he was saying that it wasn't necessarily just like mildly red. He was like, it just keeps getting darker and darker and it looks brown. But it was weird because he wasn't having like severe any other symptoms. So that's why it did seem kind of confusing.
Yeah, I would expect if someone was in like rhabdomyolysis and having hematuria that they'd probably have a little bit more symptoms, but definitely recommending them to hydrate a lot. Ultimately, it's their choice whether they want to continue the race or not. You can just provide them with information of what may or may not be going on with them.
Thanks. Thanks.
Other questions?
I don't have a question, but I just want to comment that I think that everybody did a really great job giving very in-depth overview about all these different topics and specifics about the I really enjoyed listening about the pathophysiology. Um, so yeah, just want to commend everybody for that.
Yeah, thank you so much for all our speakers. These journal clubs don't happen without speakers like them. So, for everyone listening, if you're interested in presenting at one of these journal clubs in the future, just keep an eye out for our emails as they come out. There's usually a sign up link if you're interested in one participating, but also two presenting. And we would love to have anyone who's interested volunteer to present in the future. Otherwise, have a good night and see you at the next journal club.